Hello, I'm Heidi, and I worked with Kelly, Mia, and Jalen, and we will be presenting on velopharyngeal dysfunction of cleft palate children. So what is velopharyngeal dysfunction? Well, VPD is categorized as a resonance disorder, which is a result from too much or too little nasal oral sound energy. It can result from structural or functional causes and occasionally are due to mislearnings. An example is articulation errors that can lead to the perception of resonance disorders. BPD is the inadequate separation of the oral and nasal cavities during speech and or swallowing. It is the absence of closure of velopharyngeal port and causes hypernasality and nasal air emissions. Resonance disorders should not be confused with conditions targeted by resonance voice therapy, an approach that emphasizes phonation with the least effort and impact on vocal folds. So hyper versus hyponasality. Hypernasality is excessive nasal resonance due to inadequate closing of the velum. Hyponasality is the absence of nasal speech and nasal sounds such as and due to inadequate velopharyngeal opening. We should note that when there is non-nasal speech, the velum is usually remained closed. An easier way to tell the difference between the two is that hyper is too much and hypo is too little. In the production of most speech sounds, the velum must remain moderately elevated position. High pressure consonants such as fricatives and stops require greater VP closure, and the hard and soft palate are endowed with sensors.
Awesome. So now let's get into some symptoms of hyponasality. So some people are unintelligible, which means that they are hard to understand. This is because the soft palate is not closing all the way. Another symptom is being able to hear the air that comes out of their nose when they talk. This is called audible nasal air emissions. And last but not least, sometimes food and liquids come out of their nose because the soft palate isn't completely closed.
Awesome. So we get into the question of what is cleft palate. This usually happens if the tissue that makes up the roof of the mouth does not join together completely during pregnancy. For some babies, both the front and back parts of the palate are open. Cleft lip, and cleft palate are thought to be caused by a combination of genes and other factors such as things the mother comes in contact with in her environment, or what the mother eats or drinks, or certain medications she might use during pregnancy. There could be a bilateral and unilateral shown in the picture in the slide as well. And we go into the next slide. So we get into more the populations within children, and we see that there's populations that play a role of cleft palate, such as ear infections within children, the amount of children who will have clefts, and the percentage of those who will have a abnormal chromosomal structures. So here we have within ear infections, we see that children with cleft palates are more susceptible to ear infections such as otis media than children without clefts. We see 1 in every 600 births will have a facial cleft in the United States, and this makes this the most common birth defect in the US. Excuse me. All of our babies, or excuse me, all of the babies with cleft palates, roughly around 10% to 15% are diagnosed with a syndrome, or chromosomal abnormalities. So you go into the next slide.
Okay, so thank you, Jalen. Let's jump into the anatomy and physiology. So the pharyngeal cavity is also known as the pharynx, and it is divided into 3 segments: the oral, laryngeo, and nasal pharynx. These are shaped and altered by the pharyngeal constrictor muscles. The oral pharynx includes the middle part of your pharynx. The laryngeal pharynx, or your hypopharynx, is anterior to the epiglottis and inferior to the esophagus. Your nasal pharynx is above the soft palate, contains pharyngeal tonsils, also known as the adenoids, and lateral walls contain the eustachian tubes. The elevation of the soft palate against the posterior pharyngeal wall and the passivant ridge help cut off nasal pharynx from the oropharynx. Velopharyngeal dysfunction is then the inadequate separation of the nasal and oral cavities.
Okay, so now let's get into what role does the nasal cavity play? So the nasal cavity plays so many important roles. However, in relation to our project, the nasal cavity needs to close when speaking and swallowing, as stated previously. Otherwise, air or food will go through the nose and create hypernasality. The nasal cavity also aids in phonation, which brings me to the velum. So the velum is also known as the soft palate, and this produces most of speech sounds. And when there is non-nasal speech, that is when the velum remains closed. The function of the velopharyngeal mechanism, so sorry, I skipped a part. But what does this have to do with velopharyngeal dysfunction? So the function of velopharyngeal mechanism is to create a tight seal between the velum and pharyngeal walls to separate the oral and nasal cavities for many purposes, one including speech. So moving on into the pharyngeal musculature constrictor muscles, we have the superior, middle, and inferior pharyngeal constrictor muscles. The superior pharyngeal constrictor muscle pulls the pharyngeal wall forward and constricts the pharyngeal diameter. This also contracts to narrow the nasal esophageal space. And then the middle pharyngeal constrictor narrows the pharynx, whereas the inferior pharyngeal constrictor arises from the sides of the cricoid. This is known as the cricopharyngeus, and this is important for swallowing and esophageal speech, which reduces the diameter of the lower pharynx.
Thank you, Mia. Next, we have the muscles that are involved. The tensor veli palatini tenses the soft palate and opens the eustachian tube. It is important because it prevents distortion during swallowing and yawning. The levator veli palatini is the primary elevator and elevates the soft palate. The musculus uvulae elevates and retracts the uvula. It is located medial and posterior to the soft palate. And next we have the depressors. We have the palatoglossus, and it is one of the extrinsic muscles of the tongue, brings the base of the tongue and soft palate together, and the palatopharyngeus narrows the pharyngeal cavity, lowers the velum, and may help elevate the larynx.
So now we're going to get into an article that we found that talked about typical anatomy versus VPD anatomy. So as you can see here, the levator veli palatini muscle is much longer, thinner, and discontinuous through the velar midline in children with VPD. And then the musculus uvula is also completely absent in children with VPI compared to those with non-cleft palate. And then the overall velar configuration in children with VPI makes them unable to achieve enough velopharyngeal closure that would be necessary for non-nasal speech, which makes their speech sound very nasally.
Thank you, Mia. So now we are going to briefly discuss the treatment options. So first of all, surgery is often used to try and fix the cleft palate. There are several different types of surgery that can be done depending on the size and the shape of the velopharyngeal gap. Some of the surgeries consist of narrowing the velopharyngeal space, lengthening the soft palate, a posterior pharyngeal wall augmentation, or a pharyngeal flap procedure. And while they all differ depending on the individual child, they all aim to help create appropriate closure of the velum to obtain better swallowing and speaking techniques. And cleft palate surgeries are ideally performed when a child is very young, as in about 10 to 12 months old, but really is as early as possible. And in addition, speech therapy is often utilized even after surgery because the child has already adapted to how their anatomy was previously. So they have to have therapy to help them readjust their swallowing and or talking. And speech therapy will help them to correct the abnormal placements to produce sounds that sound more accurate and less nasally. And then other than surgery and speech therapy, there are several forms of rehabilitation that can be used. And we actually discovered a new potential training method that can be performed at home. So on the next slide, we discuss this paper that we found that proposes a new way to treat VPD. And it's for individuals with either a mild cleft palate or after their cleft palate surgery. So this is not meant to replace surgery for those who have a severe cleft palate. It's more of a rehabilitation strategy, and it's accessible because it's available to perform at home. So this treatment uses a device called an in-check dial turbohaler, and that is shown in the picture. The individual would forcefully inhale using the device 10 times a day for 3 months. And in the study, they discovered that the patient's peak inspiratory flow rate, or PIF, increased, which indicates improvement in the velopharyngeal closure. So overall, this method was found to be able to not only evaluate velopharyngeal dysfunction, but actually be used as an effective self-treatment. So all of these treatment options are very important because we want to help improve the individual's quality of life. So now I'm going to discuss how surgery specifically can help do this. It is known that in addition to the physical difficulties that individuals with velopharyngeal dysfunction face, there is also an emotional aspect as well. With decreased intelligibility and communication deficits in general, people with VPD often experience emotional struggles. They might feel frustrated with people not understanding them very well, or they might feel like an outsider for sounding different than others. And for children who just want to fit in, this can be especially challenging emotionally for them. But we found a study that examined the average quality of life after a VPI repair in children, and they used a questionnaire called the VELO, or the VPI effects on life outcomes. And that included questions on speech limitations, swallow problems, situational difficulties, emotional impacts, and perception of others. And out of the 29 children, their scores on the VELO all increased from before the surgery to after. So this indicates that surgery on average is an effective way to increase and improve the individual's quality of life in physical, emotional, and situational ways. And the study also revealed that the higher levels of increased quality of life was associated with those who had more severely affected speech. So the more severe their cleft palate was after surgery, the more improved their quality of life was. So overall, surgery is typically a good option in improving the quality of one's life who has had velopharyngeal dysfunction.
All right, thanks, Kelly. So as a group, we thought about what resources would best support those as patients or the families or even professionals use. We included some websites that would support these groups. So we could go into the next slide. So here we have the ASHA website that gives detailed information about resonance disorder. This site includes the symptoms, causes, and assessments. As we have learned that ASHA is a reliable source that helps supports those who may not know about the disorder or want to gain more knowledge of it. Of course, this would be a great website as well to gain resources from, and this is where we get into the next slide of involving the American Cleft Palate Craniofacial Association. So this website is called the American Cleft Palate Craniofacial Association, and there are benefits for patients, families, and professionals involving cleft palate care. Some of the resources for families and patients on this website include basic information on the topic of cleft palates, tips, and info on feeding your baby, information on college scholarships, important terms to know, and a page of community support as well. In addition to this website, it's so helpful. It's such a helpful source for the use of professionals as it provides information on how to become a member of what they have ACPA, the benefits of this organization, and what the organization is all about. This website also has a focus on raising and building cleft palate and craniofacial awareness. And overall, this would be a great resource for these populations and provides great support for them. And so this basically concludes our presentation, and these are all of our references that we use, and we thank you so much for watching.